All right. On behalf of the Extracorporeal Life Support Organization, welcome to ELSO's special session webinar on COVID-19. My name is Elizabeth Moore, and I'm joining you from Iowa City, Iowa in the United States. It's hard to believe that it was just 19 days ago that the World Health Organization characterized COVID-19 outbreak as a global pandemic. Since that time, I'm sure many of your days have been turned upside down, much like mine, preparing our healthcare systems for the surge of ill patients that will soon enter our doors if they haven't already. Today, we've assembled a wonderful team of physicians from Japan who've graciously agreed to share their experiences and successes. This team has been treating COVID positive patients for a little over a month. And I know many of us on the front edge of the surge will greatly appreciate any insights they can offer in caring for these patients in the weeks to come. A few housekeeping items. Today's webinar is being broadcast live on our ELSO YouTube channel. That should be popping up for us here shortly. For those who weren't able to enter in the Zoom link, at the conclusion of today's webinar, the recording of this broadcast will be available to view on demand on our YouTube channel. Several questions were collected ahead of time and given to our presenters, so hopefully they'll be able to adapt some of those questions into their presentations to share with you all. And at the conclusion of the presentation, time permitting, we will be opening up for live questions and answers, so please feel free to submit your questions at the bottom Q&A tab. So before starting with our first speaker, I'd like to introduce you to my co-host for today's webinar, Dr. Reina Suzuki. She's an internal med resident at the University of Hawaii. She received her MD from Chiba University Medical School in Japan in 2013 and a research fellowship from Mayo Clinic in Rochester. A big thank you goes out to her for all of her efforts in coordinating today's webinar. So Dr. Suzuki, I turn it over to you.
Thank you very much, Elizabeth, for the great introduction. Hello, my name is Reina Suzuki, and it is a great honor for me to introduce our 5 guest speakers today. And on top of 5 speakers, we have one guest, a doctor from Japanese ECMO Society, Dr. Satoru Hashimoto. Okay, so our first speaker is Dr. Shingo Uchiba. He is the best known ECMO expert in Japan. He will talk about overview of ECMO for COVID-19 shortly. Dr. Shingo Uchiba, MD, PhD, is professor of surgical intensive care medicine at Nippon Medical School Hospital and is especially appointed lecturer at Tokyo Women's Medical University. His main research interests include management of critically ill patients without ECMO and implantable artificial lung. He has worked with ELSO since early 1990s and currently serves as the vice chair of Asia Pacific ELSO. Thank you, Dr. Uchiba. Please start.
Thank you very much, Dr. Suzuki, for invitation.
Oh, sorry. I need
sure.
to.
Yes.
Okay, let me just pull out.
Okay. So, hello everyone. Let me start my presentation. I would like to share with you about ECMO experience for COVID-19 in Japan. Next. So, I have no COI in this presentation. Next. And next. As you know, this is today's situation in the world. 598,000 people were confirmed positive so far, and 28,000 people died. And next. And this is a Japanese situation. 1,700 people were confirmed positive, including 59 severe cases. 52 people died, and 400 people recovered. The number of patients is still increasing day by day, but not overshoot yet. I think very close. the number of patients is one of the famous comedian, Mr. Ken Shimura, died of COVID-19 pneumonia yesterday. Next, please. Next. This is an algorithm of treatment of patients with severe ARDS associated with COVID-19. The indication criteria is same as the AORIA trial protocol and ELSO guidelines, with 3 major indications. And about 6% of confirmed patients developed severe condition who requires mechanical ventilation. And furthermore, some of them deteriorate rapidly and become fatal. So if the patient is about to meet the ECMO criteria, it's better sending the patient to ECMO center as soon as possible. Next, please. The ELSO guideline of ECMO for COVID-19 patients with severe cardiopulmonary failure said that ECMO is not a therapy to be rushed into the front line when all resources are stretched during a pandemic and should be treated in the expert ECMO center. The next, please. And in a pandemic situation, contraindication must be emphasized. And regarding next push. And regarding age, it is considered difficult to draw a certain line. For example, various comorbidities should be considered at the same time. Next, please. This is a study on age and ECMO outcome published in ASAI Journal 2019 by University of Maryland group. Given the global situation of the pandemic, it may be better to refrain from ECMO treatment for patients over 65. Of course, age is not the only factor. Next, please. A major 6 academic medical organizations have jointly launched the Japan ECMONet for COVID-19 since February 15. Because there are a limited number of ECMO centers for COVID-19, the consultation system was required for the hospital without experience of ECMO therapy. A 24-hour response system was provided by doctors well trained for ECMO who took turns taking telephone consultations. Next, please. As ECMO consultation, we provided comprehensive or specific educational information about respiratory ECMO through the telephone consulting service or announcement on website. Next, please. Japan is divided into 7 regions. Each region has regional ECMO coordinators. A general ECMO coordinator commands and controls for severe and difficult cases. Sometimes we discussed on the mailing list. Next, please. And another role of ECMO coordinator is managing the critical situation in the hospital without ECMO service. For example, dispatch the ECMO physician from the nearest ECMO center, and facilitation or collaboration for primary or secondary ECMO transport. And next, please. And this is a picture of primary ECMO transport. During transport, as you see, the patient is covered with vinyl. We think corona patients are safe for us during mechanical ventilation with ECMO support, as the airway is close to the air. No aerosols are generated. Next, please. This is a large size vehicle used for ECMO transport. This is the hospital of Dr. Ola. Next, please. So I'd like to share with you our typical case report from Tokyo Tama Medical Hospital by Dr. Keiki Shimizu. Next, please. The patient is a 69-year-old man without any past medical history. And he developed a minor cough and anorexia 2 weeks after boarding the cruise ship, and positive for COVID-19 in PCR test at 4 days after symptom onset. Pyrexia with 40 degrees developed on the following day, then he was hospitalized. Next, please. And day 1 showed the initial CT and X-ray of the chest on admission, and you can see the ground glass attenuation bilaterally. And on day 3, NPPV was applied, and then for Bilateral was started. Next, please. And day 6, bilateral pulmonary increased opacification and deteriorated oxygenation required intubation and mechanical ventilation. And next, please. And day 7, further deteriorated. PF was 91.4 with PEEP 10. So BB ECMO was introduced like this. Next, please. So this is a view of the cannulation through the in the negative pressurized isolation room. And the air conditioner must be equipped with a HEPA filter. Next, please. And the next. Go back one, please. Go back, please. Yes. Daytime after stabilization, the patient was transported to the one of the expert ECMO centers. Next, please. Thank you. And management of BB ECMO is as usual, intended for ultra-protective mechanical ventilation strategies. I think you should go back. Oh, yes, thank you. The ECMO setting was 2.5 to 3 liters per minute of blood flow with 3 liters of sweep gas. Next, please. And on day 14, the patient was successfully weaned off ECMO, which was 8 days of ECMO. And on day 19 of the mechanical ventilator and administration of Bilateral was completed. And next, please. So I'm going to show our summary information. Next, please. So as of 1 week ago, this is the interim report of COVID-19 ECMO net in Japan. And the number of patients, 32, and age, the median age 69, and 80% of male. And ventilator days before ECMO was 2. Data before ECMO, PF ratio before ECMO was 80 with PEEP 15. The outcome, ECMO days, median ECMO days was 12 days, and 18 patients at this time weaned off, which is a 67% of weaning rate. And 2 died, 8%, and 1 died off ECMO, and 1 died on ECMO. And all BB ECMO except 1 patient switched to BA, and 1 patient BA to BB. Next, please. So summary, ECMO was commenced for patients with COVID, viral pneumonia associated with ARDS in 32 cases, 67% successfully weaned off ECMO, and 10 still on at this time. And our experiment highlights the importance of appropriate management of basic ECMO care at the expert ECMO centers. And COVID-19 ECMO net system 24/7 days has been worked well under these circumstances so far. But we are pretty sure that if more serious pandemic occur, our system will not work anymore. Next, please. So issues to be concerned. The indication in pandemic may be affected by the number of critically ill patients in the nation and resources, medical resources, and the number of ECMO beds and so on, and policies. The prong on ECMO, I think we should avoid risk of our infection. And PPV during cannulation may be talked by Dr. Ogura, and CRT and multiple organ failure may be taught by Dr. Abe, and ELSO by exhaust from oxygen is going to be taught by Dr. Liu. And VA for cardiac failure or profound septic shock was 1 or 2 cases in our series. And ECPR not yet, but probably we should, it should be avoided. And withdrawal, not yet. And as for resources, we have domestic manufacturers, but production may not be able to keep up in the near future if pandemic is more serious. The next, please. So we keep fighting COVID-19. Thank you very much.
Thank you very much, Dr. Ichiba, for a great overview for the ECMOnet. So as in housekeeping stuff, we are going to have a collective Q&A session after the 5 speakers done. So please feel free to send a Q&A session from the bottom ribbon. Okay, so our second presenter will be Dr. Ichiro Takeuchi. So he's actually the doctor who saw the first ECMO case from the Diamond Princess, the cruise ship at Yokohama. So he will shortly talk about his experience. So Dr. Takeuchi is MD, PhD, is a professor of the Department of Emergency Medicine at Yokohama City University Graduate School of Medicine. He is board certified in internal medicine, cardiology, emergency medicine, and critical care medicine. While leading one of the largest emergency departments in Yokohama, Japan, he serves as a core member of many important committees in the emergency medicine and critical care medicine, as well as COVID-19 related committees hosted by the Japanese government. Okay, so Dr. Takeuchi, please feel free to start.
Okay, thank you very much. And you can see my slide, okay?
Yes.
Okay, all right, I will start. I'm Ichiro Takeuchi, Chief Professor of Yokohama City University. And my presentation title is How We Treat Cruise Ship Diamond Princess with 3,700 Passengers. And in Japan, first COVID-19 case is very early time, that it was January 16th. And then we have made efforts not to spread coronavirus. And this slide shows the spread speed comparing with the countries. You see in Italy, the death number is increased rapidly. And in France, first period, it is not so fast, but after the first case of death, 20 days later, the spreading speed, death rate increased rapidly. And UK and USA is also increasing, but you see Japan, it is very low. And the first case was January 16th, and still Japan, death rate and spreading speed is very low. So still now Japanese medical system is not collapsed. And how we treat cruise ship Diamond Princess with 3,700 passengers, in it 700 corona positive patients, and why emergency medical system in our city, in Yokohama City, was not collapsed. So February 3rd, the cruise ship arrived at Yokohama port, and quarantine for 14 days began. And 2,600 passengers in it, and also about 1,000 crew. So total number of the passengers were about 3,700. And passengers, most of passengers were above 70 years old. And novel coronavirus PCR was examined. And PCR positive passengers were transferred to the hospitals. This is each day how many patients were transferred to the hospital. February 5th, it was just only 10 passengers, and February 6th, only 10. But after February 7th, the number of passengers who transported to the hospital was increased rapidly. And February 10th, about 60 passengers were transported to the hospital, like these many ambulances. And if PCR positive patient, about 700 passengers were transferred to the Yokohama City Emergency Hospital, we afraid EMS collapsed. And also we have to balancing have balancing with regular EMS patients, like trauma patients or ACID patients. And in Italy, maybe it occurred, EMS crisis was occurred. And one of the reasons is corona positive slight illness patients and serious patients and super severe patients. All patients went to the hospital, and also regular EMS patients also transferred to the hospital. So that's one of the reasons in Italy EMS service was collapsed. So we avoided to these things from the cruise ship. So we sent medical team to the cruise ship, and on board medical team, they divided into 3 groups by medical judgment. I mean, urgent treatment group, red group, they have dyspnea or SpO2 below 94%. They need, some patients need intubation, or ACS or cerebral infarction patients. Those patients were transferred to emergency center in Yokohama as soon as possible via fire ambulances. And yellow group, they need medical treatment like O2 supply. Those patients were transferred to hospital in Kanagawa Prefecture within 2 hours. And the green group, PCR positive, but they are no symptom. They were transferred to distant hospital 3 hours and more by bus together. So we focus balancing with regular EMS system and parallel with accepting patients from regular ambulance. That was very important thing. This is summary. Transportation due to need for emergency medical care. The patient were transferred to medical facilities in our city, Yokohama City. The red group patient was 64. And the yellow group, they were transported to medical facilities in Kanagawa Prefecture. The number was 102. And the green group, medical facilities, they were transported medical facilities outside of our prefecture. The number was 346. And in my university hospital, we accept 20 patients, COVID-19 patients. And we are emergency critical care emergency advanced department, so we had severe COVID-19 patients. We used ECMO to 3 patients and ventilator to 6 patients. And also other patients, severe disease with corona positive, like ACS with corona positive. The patients need immediate PCI and perforation with corona. The patient need emergency surgical operation, and also severe infection patient with corona positive. The patient get immediate catheter. And this is death rate compared with the countries. In Italy, the death rate is about 9.3%, and Spain is 6.2%. In Japan, now it's 3.7%, and the death rate of cruise ship among PCR positive patients, that was only 1.1%. That was very low compared with other countries and also other regions in Japan. And lessons from cruise ship: to avoid emergency medical care system collapse. If all PCR positive patients go to the hospital, it would be overshooted. So corona positive but slight illness patients should be in their home. And corona positive serious illness patients, they transfer to emergency hospital and they have oxygen on bed. And corona positive super severe illness patients should be transferred to emergency center, and they may need ventilator or they may need ECMO. So balancing with accepting regular EMS is very important, I think. And you can see the detail in Acute Medicine and Surgical Journal online publication, how we treated the Diamond Princess patient in detail. And next, treatment. This is the first case of ECMO in Japan from Diamond cruise ship. And also you can see the detail in acute medicine and surgery. Now it is online publication. And that was the first case in Japan to COVID-19 patients. And now Dr. Ichiba already explained, now in Japan, we use ECMO, total 36 cases and 20 cases already success. And also 13 cases are ongoing with ECMO, and unfortunately 3 cases were dead. And medical treatment, this is Japanese TB program. Also in Japan, we use Abigan, favipiravir, and also remdesivir, and Caretola, lopinavir and ritonavir, and also shicloxanide. So now we are discussing which is the best treatment to the COVID-19 patients, but now we don't the result which is the best. So in hospitals, maybe the treatment is a bit different, I guess, in Japan. And how about IL-6 inhibitors? This is our university hospital patients' data. Now we are checking COVID-19 cytokine levels, including IL-6, IL-10, and interferon alpha and beta. But now still we are under examination, and now we are making reports about that. So later, maybe you will see the result of the cytokine level in the COVID-19 patients. And in Japan, most people have vaccine BCG. And some reports say vaccine BCG may provide immune boost against coronavirus, herpes, and other viral infections. So this is one of the reasons why in Japan, the spreading speed is very low compared with other countries. So it may be one of the reasons, but I'm not sure now. Thank you for your thank you for your attention.
Hey, thank you very much, Dr. Takeuchi, for your very important experience from the cruise ship. So now, we're gonna move on to our third speaker, Dr. Takayuki Ogura. So he will shortly talk about a case from his hospital. So Dr. Ogura, MD, PhD, is an emergency medicine-based critical care physician with a special interest in ECMO and the director of Emergency and Critical Care Center at Utsunomiya Saiseikai Hospital. As a researcher, he received the American Heart Association Resuscitation Science Symposium Young Investigator Award for 6 years in a row from 2012 through 2017, and the Best Award at the symposium in 2018 for his works in trauma resuscitation. Not only leading ECMO projects in Japan as a young leader, he's also a member of World Health Organization Emergency Medical Team project since 2018. So thank you, Dr. Ogura. So please start. Dr. Ogura, please unmute.
Can you listen? Okay.
Okay, we can hear you.
Okay, thank you very much. Hello everyone, my name is Takayuki Ogura, MD and PhD. Call me Taka. Thank you very much for giving me this opportunity to present my case of COVID-19 ECMO patient. I am an emergency critical care physician in Japan, and I learned ECMO in UK from 2015 to 2016. Now, I am a general ECMO coordinator in Japan ECMONet for COVID-19, and I command the several ECMO cases as mentioned earlier by Professor Dr. Ichiba. Japan ECMONet provides these services, including ECMO consultation, ECMO coordination, ECMO coaching in the district hospital and ECMO transport. Today, I will present a typical COVID-19 ECMO case, and I will show the operation of the in our hospital. The case is 57-year-old male, and he has a history of heavy smoker, but he was not diagnosed as a COPD before the admission. He had a vacation in EU from February 24 to March 2nd. After going back to Japan, his fever had been up to 7.5 degrees. He observed, but unfortunately, his fever had been up to the 9.5 degree at the March 9th. We checked the PCR and his result was positive. This is a chest X-ray at the admission. A small GGO at the left lower lobe was found. He had no need of oxygen and he had no symptom. But at the time that every COVID-19 patient must be admitted to the designated medical institution. So he was admitted to the referral hospital with the negative pressure room. The hospital day 3, the chest CT was performed in the referral hospital. The GGO is spread from the left to right. At this point, he needs some oxygen, but he had still no symptom. At the hospital day 7, his symptom was rapidly worsened and his respiratory rate went to over 30. He was severely desaturated and the intubation was performed. At this point, before the intubation, the referral hospital called to the Japan ECMO net, and I started the convention for ECMO transport to the ECMO center. I get a call from the referral hospital on March 14th. I monitored this patient by frequent telephone-based consultation. I ordered the intubation at the March.
Sorry, I guess Dr. Ogura kind of dropped. His connection might not be too great. Hopefully he can come back soon. Dr. Ogura, you're okay? You're dropped. Okay, please start.
Sorry. So I get a call from the referral hospital March 14th. I'm collaborated with the doctor in the hospital and the conventional transport. After the transport, we used the muscular relaxant, but his pressure was rapidly getting worse.
Dr. Ogura, I'm so sorry to interrupt during your presentation, but unfortunately, so you might need to find a better place with a better internet connection. And then meanwhile, we're gonna start our fourth presenter, Dr. K-Boon Leal, if you don't mind. And then, so is that okay with you, Dr. Ogura? Okay. Okay, we're gonna move on to Dr. Kevin Liu, our fourth speaker now. Dr. Liu, please start sharing your slides. So Dr. Liu, MD, PhD, is an emergency medicine-based critical care physician at Utsunomiya Saiseikai Hospital and shortly a research fellow at the Prince Charles Hospital in Australia. So he received MD from Tokyo Jikkeikai Medical University in 2012 and a PhD from Jichi Medical University in 2019. He's one of the young leaders in the field of emergency medicine and critical care medicine in Japan. His main research interests are in early mobilization and ECMO, and he will talk about a very interesting topic today of aerosolization via membranous oxygenator. Okay, thank you very much. Dr. Liu, please start.
Thank you for your introducing me and inviting to this special webinar. I'm very honored to speak with these outstanding ECMO experts in Japan. So my name is Kevin Liu from Japan, emergency medicine and intensive care physician. So today, what I would like to focus on is the virus permeability on ECMO and the coagulopathy in COVID-19 patients. So these are my agenda. So first, I'm going to talk about the virus permeability following coagulopathy. Unfortunately, there is no sufficient data on these topics so far. So please note that both lack of data at this moment. So let's start with this topic. So as we know, there are 4 types of ECMO membrane, including a porous membrane, composite membrane, asymmetric membrane, and homogeneous membrane. In Japan, the composite or asymmetric membrane is most used for VV ECMO. And the diameter in one hole of porous on ECMO membrane is approximately 0.04 to 0.10 micrometer. And the diameter of COVID-19 is 0.06 to 0.14 micrometer. So the diameter of COVID-19 is similar to that of a hole on ECMO membrane. So, but the membrane generates certain charge and potential based on the surface coating and the materials. So it should prevent COVID-19 from crossing over the membrane. So theoretically, the risk that COVID-19 spread from the ECMO membrane is lower than general respiratory tract with endotracheal tube and the mechanical ventilation because these are closed loop. But the however, what we should bear in mind is the plasma leak. When the ECMOS period is long and the membrane becomes deteriorated, we sometimes see the plasma leak from exhalation port of artificial lungs. So this could generate aerosol with COVID-19. When the plasma leak occurs, the diameter of one hole on membrane gets wider and the membrane loses its charge and the potential. So COVID-19 could go through the membrane in this condition. So you should consider the risk of aerosolization with COVID-19 and the spread of infection during plasma leak. To investigate the virus permeability, we did PCR testing from the sputum and exhalation port water when the membrane deteriorated, but no plasma leak, like this figure. So the sputum PCR was positive, but the PCR of exhalation port water was negative. I did twice, but I get same results. However, other hospitals in Japan did PCR of exhalation port during the plasma leak and showed positive. So COVID-19 might be able to cross membrane, especially during the plasma leak. So we should think about the possibility of virus permeability with serious cautions. So what we can take on this risk is that lowers the threshold of changing the lungs. So we should change the lung before starting plasma leak. and we should take some measures to prevent the spread of aerosol from the exhalation port, especially during transport, such as transport to CT room or retrieval transport to a hospital. So I think double cover would be better to prevent it so far. So let's move to coagulopathy, a topic in COVID-19 patients. So many papers demonstrated that non-survivors of COVID-19 showed more severe coagulopathy disorders. Over 70% of non-survivors showed DIC at their late phase of ICU stay. And several papers pointed out that coagulopathy is associated with the severity of disease progression, the development of ARDS, and mortality. So considering this evidence, we can say that severe case of COVID-19 apparently cause coagulopathy. So unfortunately, the evidence of the underlying mechanism of the coagulopathy is still unclear. Some papers suggested the cytokine storm and hyperinflammatory status as a cause of coagulopathy, but we need more data on this topic. But what we can say from the current experience, the severe case of COVID-19 could be obviously classified into hyperinflammatory ARDS phenotype. From the current experience in Japan, we had some breathing complications such as intracranial hemorrhage and hemothorax. The breathing complications seems more frequently than thrombus complication in Japan. Interestingly, some severe cases show the DIC with hyperfibrinolysis. We need to keep collecting this data on coagulopathy and complications. So what we could say on this topic is coagulopathy might be one of the indicators to be monitored whether the patient become worse or not. And the coagulopathy and the cytokine storm, which might cause coagulopathy, might be targets to be treated because these are associated with the progression of disease and mortality. To establish the appropriate therapeutic strategies against these, we need more data on this topic. These are my keynotes of my presentation. First, the risk of spread of COVID-19 from ECMO membrane in normal condition is considered low, but COVID-19 could cross over the ECMO membrane, especially during the plasma leak. So second, severe case of COVID-19 showed coagulopathy, which is associated with the severity of and the mortality. Third, coagulopathy might be an indicator of disease progression and a target to be treated. Thank you for your attention.
Thank you very much, Dr. Ali, for a great presentation. It was a very interesting topic for everyone, I think. So now, we have Dr. Ogura back. I hope he could have better internet connection now. Are you ready, Dr. Ogura? Okay, please unmute, and if you could start from, yes, the case presentation. Right, thank you.
Okay. Okay, sorry, I want to present again. So the case is a 57-year-old male. He had a history of the heavy smoker, but he was not diagnosed as a COPD before the admission. He had a vacation in EU, and after going back to Japan, his fever had been up to 7.5 degrees. And he observed, but unfortunately, his fever had been up to 9.5. We checked the PCR and his result was positive. This is a chest X-ray at the admission. The small GGO at the left lower lobe was found. He had no need of oxygen and he had no symptom. But at the time, the Japanese government had decided that every COVID-19 patient must be admitted to the designated medical institute. So he was admitted to the referral hospital with a negative pressure room. The hospital day 3, the CT was performed in the referral hospital. The GGO is spread from the left to right. At this point, he needs some oxygen, but he had no symptom. At the hospital day 7, his symptom was rapidly worsened, and his respiratory rate was went to over 30. He was severely desaturated, and intubation was performed. At this point, before the intubation, the referral hospital called the Japan ECMONet, and I started the planning of the conventional or ECMO transport to the ECMO center. I get the call from the referral hospital at March 14th. I monitor this patient by frequent telephone-based consultation, and I ordered the intubation at March 15th. Next day, I got the information that he was still getting worse and his PF ratio was decreasing to 100. I dispatched the ECMO physician to the hospital. The hospital day 9, we collaborated with the doctor in the hospital and the conventional transportation with ventilator was performed. After the transport, we used the muscular reluctant, but his PF ratio was rapidly getting worse. The chest X-ray showed really expanded GGO in all areas of his lung, and his PF ratio was 80 at this point. Finally, we decided to perform the ECMO. At the cannulation, we can't use the X-ray in ICU, but we can use transesophageal echocardiography. We detected the wire in the IVC and the right atrium. The cannulation was successfully completed. The Dolenite cannula was located in IVC, and the Lytton cannula was located in right internal jugular vein. We won the fully personal protective equipment with cap, face shield, N95 mask, gun, and glove. But we did not wear Tyvek suits. Here is the view of the CT just after the ECMO landing. His GGO was extremely expanded. A new consolidation and atelectasis was happened in his dorsal side. There was no traction, bronchiectasis. This view suggested that his lung injury was potentially reversible. The photo shows the usual ECMO clinical scenes. The staff takes maximally care for the inhalation of the ELSO, but no Tyvek and PAPRs. IV pump is inside the room, and the monitor is also inside, but the monitor is centralization. The ECMO staff is always staying outside of the room and observe the patient through the window. The patient is a little bit more deeply sedated, and the staff enters the room with PPE if needed. The mic was set inside the room, and the communication leader is outside during the staff is inside. We don't know the answer, but there is no report of the second COVID-19 infection of ECMO staff in Japan. We chosen the chosen ABX is Bilateral. Ventilation setting after ECMO landing is here. The setting is completely lungless setting with only 8 frequency of ventilation. The monitored tidal volume was 180. I will show the major complication of this patient. This patient showed the small intracranial hemorrhage before the ECMO. low-grade AKI and drug-induced liver injury was found. And more, hemophagocytic syndrome was also diagnosed clinically. And other complications related to ECMO management happened. In this case, high D-dimer was identified before the ECMO initiation, and this data suggested that the coagulopathy was already existed. And more, after ECMO running, much clotting in the artificial lung was occurred, and we had hard anticoagulation management. We hypothesized that the background of this phenomenon is hyperinflammation, but the truth is completely unclear. This is a view of the chest X-ray at the ECMO day 7. The ventilation setting is same. The DGO is gradually improved. Here is the chest CT at the ECMO day 7. The DGO remained, but slowly improving. This view showed no bronchial dilatation, so we consider that this lung injury is still probably reversible. We can perform CT for the COVID-19 patient. That is because the access route to CT is distinct from general patient. The CT room was fully disinfected and left open for more than 12 hours after the taking image. Still, now we are fighting. Let's do our best for this difficult situation. Thank you for your attention to my presentation and Japan ECMONet for COVID-19. Thank you.
Okay, thank you very much, Dr. Ogura. We're glad we're able to hear all your presentations. Okay, so our last presenter is Dr. Ruzo Abe. So he will shortly talk about multi-organ dysfunction in COVID-19 patients. So Dr. Abe is Associate Professor of Department of Emergency and Critical Care Medicine, Chiba University School of Medicine. He's board certified in surgery, emergency medicine, and critical care medicine. He received an MD and PhD from Chiba University Graduate School of Medicine and also postdoctoral fellowship at Yale University School of Medicine. In recent years, his main interest has been improving patient outcomes with ECMO, including ECPR. He is currently a core committee member of ECMO projects in Japanese Society of Respiratory Care Medicine and Japanese Society of Intensive Care Medicine. Thank you, Dr. Abe. So please feel free to start.
Yes. Thank you for your introduction, Dr. Suzuki. And good morning and good afternoon and good evening, everybody. My name is Ryuzo Abe. In the last part of this webinar, I focus on multiple organ dysfunction in COVID-19 cases. Before I start, I briefly introduce my institution, Chiba University Hospital. Chiba University Hospital. Since we had the first ECMO case in 1993, the number has been constantly increasing to around 50 cases a year. Half of the cases underwent ECPR for out of hospital and in-hospital cardiac arrest. Survival rate to ECMO removal is around 60 to 70%, and survival to ICU discharge is between 55 to 60%. Regarding respiratory ECMO, we have 10 to 15 cases a year. In cases in 2019, ECMO survival and ICU survival rates were 78 and 71%, respectively. Indication criteria for respiratory ECMO in our hospital is PF ratio less than 80, and APRV more mechanical ventilation and nitric oxide inhalation. Exclusion criteria is as shown. At the present time point, the criteria is completely the same as usual, even for COVID-19 patients. Many of COVID-19 patients have common cold-like symptoms, and some of them develop pneumonia. It is not clear who and how multiple organ dysfunction develops. In the report from China, the most frequent organ dysfunction was ARDS, followed by shock, cardiac injury, arrhythmia, and AKI. I'm going to show a case from perspective of organ dysfunction. 73-year-old man who has medical history of hypertension and dyslipidemia was traveling on the cruise ship. He had a sudden sensory neural hearing loss, and prednisone was prescribed. 7 days later, he became febrile and developed dyspnea and cough. Due to the outbreak of COVID-19 on the cruise ship, PCR test was performed and turned out to be positive. Therefore, he was transferred to a regional hospital according to the Japanese government quarantine policy. After admission to the general ward, his general condition was good, and he didn't need supplemental oxygen. Chest CT on day 4 revealed the progressive ground glass opacity, so lopinavir, ritonavir was initiated. Supplemental oxygen was started on day 6 since his respiratory status slowly deteriorated, requiring oxygenation with 15 liters per minute on day 10. Then he was intubated and transferred to the ICU in University Hospital. Upon ICU admission, PF ratio was 186 on 10 centimeter A2O PEEP. Chest CT revealed progressive GGO and atelectasis in the dorsal side of the lung. We usually apply prone positioning to such type of patients, but in this case we didn't, because PF ratio was not very low, and we wanted to avoid risk of transmission. We performed bronchoscopy in full personal protective equipment, utilizing disposable bronchoscopy and display covered by double plastic bags after administration of rocuronium to minimize the risk of aerosol generation. No purulent sputum was observed and presented no evidence of bacterial infection in the gram stain and culture. Sputum looked like pink bubble, which was consistent with ARDS. During the initial 6 days in the ICU, PF ratio had been kept between 120 and 180, but nitric oxide inhalation and APRV mode mechanical ventilation were required. ECMO was not indicated. Body temperature sustained around 39 degrees Celsius. Although lopinavir, ritonavir was continued and interferon beta subcutaneous injection was initiated, PCR tests have been positive in sputum and blood samples, indicating persistent viremia. Persistent viremia induced excessive inflammatory reactions suggested by sustained high blood level of interleukin-6 and other biomarkers. High magnitude of inflammation might lead to organ dysfunctions, suggested by elevation of SOFA score. He needed noradrenaline to maintain hemodynamics on ICU day 3 and continuous renal replacement therapy for acute kidney injury on day 4. In addition, he developed DIC, indicated by constant decrease of platelet count and rapid increase of FDP on day 5. On ICU day 6, he complicated respiratory, cardiovascular, kidney, and coagulation dysfunction, resulting in SOFA score of 13. Since we intended not only to support failing organ functions, but also to modulate excessive inflammation, we utilized cytokine adsorbing hemofilter for CRRT. According to our institutional protocol, nafamostat was administered as an anticoagulant. My department has been investigating cytokine modulation in sepsis for a long time. In this case, we chose an N69ST membrane hemofilter. However, on ICU day 7, respiratory dysfunction exacerbated and PF ratio dropped to 72. Therefore, BV ECMO was initiated to maintain his oxygenation. ECMO was induced in the negative pressure room in the ICU by limited number of staffs to avoid transmission. In addition to full PPE, doctors had to wear X-ray protector and sterile gown. Cannula were inserted percutaneously using ultrasound and portable X-ray. Puncture was performed by a real-time ultrasound guided technique, and the position of guide wire and cannula were recurrently checked in the X-ray display. Drainage cannula was placed in right atrium through right jugular vein, and outflow cannula was through right femoral vein, according to our institutional protocol. ECMO was set as shown. Blood flow was set at 4 liters per minute. Different from usual protocol, ACT, activated clotting time, was measured every 6 hours, while it is usually measured every 2 hours in order to decrease frequency of entering into the room to minimize the risk of transmission. After ECMO started, on ICU day 10, chest X-ray presented white-out appearance. No detectable tidal volume was observed. We switched lopinavir ritonavir to favipiravir, supplied by Japanese government. Frequent exchange of ECMO circuit was needed every week. That might be caused by dysregulated blood coagulation system, even though ACT and APTT were controlled within targeted range, as same as other presenter demonstrated. As his respiratory condition had not been improved, tracheostomy was performed on ICU day 30. He is still in the ICU on ECMO. As same as pathophysiology of sepsis induced by bacteria, COVID19 induced pneumonia and viremia, followed by excessive inflammatory reactions, leading to multiple organ dysfunctions, including ARDS, AKI, shock, and DIC. We can support such organ functions using ECMO, CRRT, and drugs. However, as we know, we have to resolve the root causes of disease, which means drugs against the virus and modulation of inflammatory reactions by cytokine absorption. Based on my experience and the information in our network, successful ECMO case may have only respiratory failure, even if it develops within quite short time. This is suggested by very short duration of mechanical ventilation days before ECMO. That was 2 days in the database of Japan ECMONet. To the contrary, difficult case may develop multiple organ dysfunction before PF ratio decreases. DIC might be a predictor of poor outcome. I have no idea why some patients develop radical respiratory failure and others develop other organ dysfunctions. But we may have to think of restriction of ECMO indication for this type of patients. To summarize, multiple organ dysfunction might be induced by excessive inflammatory reactions in COVID-19. ECMO can be useful for patients who have only respiratory dysfunction as long as it is initiated within due time, while the deterioration of PF ratio is quite radical. Patients who have multiple organ dysfunction may be excluded from ECMO criteria according to the regional situation. Cytokine absorbing therapy can be an option. At least at the present moment, ECMO is applied according to usual protocol in Japan, but nobody knows the situation tomorrow. Thank you for your attention, and I sincerely hope all of you will take good care of yourselves and your family. Thank you.
Thank you very much, Dr. Abe, for the great experience from your facility. So now, because we only have 20 more minutes to go for our Q&A sessions, we're going to directly move on to our Q&A session. So our first questions we have is for Dr. Satoru Hashimoto, who is the technical lead of ECMONet database, as far as I understand. So Dr. Hashimoto, so the question is, how you have been collecting data, and also how you have been sharing that information with participating facilities in ECMONet.
Okay, good evening. So it's a very good question, and I'm not sure I can answer you correctly. because there are so many difficulties to get data from different kind of hospitals, because so far we had nearly 40 cases. The presenter showed it 32, but now we have 39 or 40 cases. It is very difficult to get data from each hospital because, you know, it's kind of secretive. They don't want to share the data with us. So we need time to get the old data. Probably we should talk to every doctors to get together and collect the data. You know, right now we don't have enough data to publish to the like big journal. So we have to get together to collect the data. But at least we have a network and there's a surveillance system. So we can at least collect how many ECMO cases we have in Japan. Is that the correct answer for you?
Great. Thank you very much, Dr. Hashimoto. And then, okay, yeah. So yeah, thank you very much. So, do you have anything like from the panelists, anything to add or anything? No, seems like
me?
nothing. Okay. All right. Okay. Thank you so much, Dr. Hashimoto. And then we're going to move on to our next question. So, and actually we have a lot of questions for Dr. Liu about coagulopathy. So there are too many. So let us just pick up like a couple which has been addressed like multiple times. So the first thing, is there any specific anticoagulants you're going to choose for the COVID-19 patients?
Thank you for many questions for me. So in this case, we don't use a specific treatment for coagulopathy, but some patient with showing DIC with hyperfibrinolysis, we use nafamostat, but we very careful to use anticoagulation because some cases show very severe bleeding complication. So we need to monitor APTT or ACT very carefully, like 6 hours, every 6 hours, as a panelist showed. So in this case, we use like this.
Okay, so thank you. So then in terms of APTT, there's a question if we should like target higher APTT for COVID-19 cases.
Actually, not different from other ECMO patient. My hospital, the criteria is 40 to 50 or 40 to 60 usually. So much different from other ECMO patients.
Okay, so the next question is, yeah, thank you so much, Dr. Liu. So next question is probably both for Dr. Abe and Dr. Liu. So were you using polypropylene PMP oxygenators to have plasma leakage? Oh, no, sorry. Oh, no, sorry. Any thoughts or experience with plasma exchange to remove cytokines and improve coagulopathy? Dr. Abe or Dr. Liu, would you be willing to take this question?
I think we use polymer. I'm sorry.
Oh, no, sorry. So it's about plasma exchange to remove cytokines and possibly improve coagulopathy.
No, I don't, because usually we think there's cytokine absorbing hemofilter cellularity. We work there, so we don't use plasma exchange for in the purpose of cytokine modulation.
Okay, all right, thank you very much, Dr. Abe. So, okay, So, and also there's a question, like if there's any specific treatment for hyper or hypocoagulability, coagulopathy in this like COVID-19 ECMO patients. So there are a couple agents mentioned here, antifibrinolytics in treating the coagulopathy, and bilateral as an anticoagulant. So I think those two are mentioned. Any thoughts about this, Dr. Liu?
So the principle of treating DRC is the baseline to treat the baseline disease. So we should not focus on DIC, but focus on treating the virus treating. So I think there is no specific treatment on DIC or coagulopathy in this case.
Okay, so basically, yeah. Oh, sorry, Dr. Abe, please go ahead.
As Dr. Liu mentioned, nafamostat is used for some patients in this country. I mean, in my patient, we used nafamostat as an anticoagulant for CRRT. After ECMO started, we start heparin, but there might be effect on of the nafamostat. It's a protease inhibitor, where I think it's a domestic drug, but it is used for DIC and pancreatitis, and it might have an effect on the coagulopathy in this disease. But as I mentioned in my presentation, the ACT and APTT was controlled within the targeted range, but the coagulation was hypercoagulation was observed. So we don't know what is happening.
All right, yeah, thank you so much for Dr. Abe and Dr. Liu. So we understand is basically there's no specific treatment, like we're gonna try to target like actual like underlying disease, the COVID-19. So the next question is about like lungs, so the proning. So there are a lot of questions about prone actually. So do you recommend, what is the experience regarding prone? Either prior to making patients on ECMO or the patients during ECMO. Dr. Ichiba, yeah. Would you be able to? Oh, Dr. Takeuchi. Okay, so would you be able to help?
Okay. I think prone position is one of the best way to improve the bad lung. But we have to think about how we protect staff's infection from coronavirus disease. So NPPB and nasal high flow is also could be aerosol. So in our hospital, 2 COVID-19 patients, we don't not so much time to prone positions because turning the position of the patient could be sometimes dangerous to staffs, and so I think we should be careful to do in such things.
Thank you, Dr. Takeuchi. So Dr. Ichiba, is there anything you would like to add?
Yes, I agree with the idea of Dr. Takeuchi. And if the patient CT scan shows the typical ARDS baby lung, like a baby lung, maybe we should think about proning the patient on before and on ECMO, but the risk, we have to think about the risk of our infection. So I think it's better to avoid doing so.
So both experts are waiting toward not to do the prone for now. Okay, yeah, thank you so much. So the next question we have is there any role on systemic steroid or IL-6 inhibitors for COVID-19 ECMO patients?
Yeah, I think that is difficult to answer. So now we are collecting the data in Japan. Maybe not so many cases were used IL-6 inhibitors. So we are collecting the data. So now we cannot have the result of how is the effect IL-6 inhibitors or other drugs to COVID-19 patients. We have no answer in Japan.
Thank you. And any experience with favipiravir? Anyone? I think that's Abigail.
I want to say about the IL-6 inhibitor.
Oh yeah, sorry, Dr. Abe. Please go ahead.
Is that okay?
Yeah, sure.
I think as same as other sepsis pathophysiology, the specific cytokine inhibition that doesn't work. I mean, the hypercytokinemia it's the problem because there are so many kinds of modulator are elevated. So specific inhibition must not work, I believe.
Great. Thank you so much, Dr. Abe and Dr. Takeuchi. So, sorry, we have very long list now. So, okay. So, any difference in BV ECMO setting between ARDS and ARDS from COVID-19 as regard initiation or weaning ECMO? Okay. Is there anyone?
Yeah.
Okay, Dr. Ichiba, please go ahead.
Yes, basically it is not different between ARDS associated COVID-19 and usual ARDS. The indication criteria we use is the same as the AORIA and also ELSO guideline. And weaning criteria is also same.
Okay, thank you very much, Dr. Ichiba. So now we are running out of time, unfortunately. So we're gonna return to Elizabeth from ELSO.
Thank you so much. And I know we had a fury of questions there at the end. So the good news is I'll be mentioning shortly, we will be doing another webinar coming up as well. We'll try to catalog all these questions and see if we can't continue to get the information out. So thank you again to all the speakers. It was a fantastic discussion today. Thank you to Dr. Suzuki for assistance with hosting. I want to thank Velia Antonini, even though she wasn't able to be on tonight. She's on shift. But thank you for her many talents in sharing the information across the multiple social media venues. She will have all of our slides posted later this evening. A few reminders as we log off on elso.org. We still do or have added a tab for COVID-19. So if you haven't already done so, take a few minutes to review the data available on the site. Realize that we are trying to update that in real time. As well, keep an eye out on our various social media posts to just have updated information will be pushed through that venue. And as I alluded to, our next webinar will be tentatively scheduled for this Friday, probably about midday in the US time. We are looking to welcome some speakers from New York, Seattle, and Paris, as well as sharing some of the most popular chats, questions, and best practices from the past weeks on WhatsApp. So stay tuned for all of that. And thank you again. Everyone stay safe, and we will see you again very shortly. Thanks so much.
Thank you. Bye-bye.
Thank you very much.
Thank you for inviting me to this special webinar. Bye.